Welcome, everyone. I'm Dr. Joe Gogler, professor and Robert L. Kane Endowed Chair in Long-Term Care and Aging in the School of Public Health here at the University of Minnesota. I also direct our Center for Healthy Aging and Innovation. Welcome to the final session of Mini Medical School Aging and Health. We, again, are so excited to have you here today, and we look forward to guiding you through our third topic of the series, Thriving, Mental Health and Wellbeing. I hope you were here the past few weeks to hear our introduction to aging and creating pathways to healthy aging. If you're not able to join us, we encourage you to watch the recordings after this session. So we will begin with a moderated discussion followed by a question and answer session. You can submit your questions to our panelists at any time using the Q&A box, which can be found by clicking on the Q&A button at the bottom of your Zoom screen. Please note that the session is being recorded and will be available starting tomorrow on the Office of Academic Clinical Affairs YouTube channel. We will share the link to the recording with you by email as well. So one thing, one quick item I wanted to bring to your attention is I am so thrilled and proud to have moderated the mini medical school over the past couple weeks and tonight as well. Many of, if not all of the panelists are actually members of our Center for Healthy Aging and Innovation. And you see a little bit more information about our center here. It really operates as a university-wide center with the goal of a community, state, tribal nation, country, and world where everyone can achieve their life goals while aging. As you can see, we have a very vibrant and large membership as part of our center. And I hope after today, you can continue to explore with us many of the important life-altering topics as they relate to aging. And this is the work that CHAI does on a day-by-day basis. Please do feel free to visit us on our website. You can see the link here. Do follow us on Twitter at UMNCHAI, and then you can also email us at chai@umn.edu at any time. We're happy to answer any question you might be interested in. As well, if you're interested in being a member yourself, we can always discuss those options with you as well. Thank you. So again, last week we discussed creating pathways to healthy aging. Today we have the privilege of speaking with a panel of experts on nutrition and aging, resources for medication management, and improving quality of life. And now let's turn to our panelists. And first we'll bring in Dr. Brian Isets. Dr. Isets is a professor in the College of Pharmacy and a pharmacist with over 25 years of experience working as a nursing home consultant, as well as in the community and in institutional practice. Dr. Isets is a board-certified pharmacotherapy specialist and seeks to improve medication effectiveness and safety for patients of all ages. Dr. Isets, can you discuss best practices for medication management?
Yes, Joe, for sure. Thanks for the introduction and invitation to be here today. My name is Brian Isets. I'm a pharmacist, a geriatric practitioner, and a professor at the University of Minnesota College of Pharmacy. And I'm very excited to be here this evening for two reasons. And first of all, in my opinion, Mini Medical School is one of the best academic health center initiatives we've ever created. In my opinion, it provides practical ways to get cutting-edge medical innovations into the hands of individuals and stakeholders in an understandable manner. And second is because I've been waiting a long time to get this opportunity, to get this chance to share the outstanding information we have here today. I've worked much of my life with the patient and family engagement community to help understand what people are going through when they are taking medications. This really is a life-altering topic. And so here we've had Mini Medical School for almost 20 years, and finally I get my 12 minutes of fame, if you will. So we're going to talk about effective medication management, making sense out of medications. Here are the three questions to run on I want you to think about as we go forward. Why has the process of taking medications become so complex for many people? It doesn't have to be that way. Can a new way of thinking help individuals better understand the medical reasons for taking each medication, how they're supposed to work, which safety concerns are specific to them, and then how best to take and afford medications? And then how can we collaborate more effectively to help individuals confidently self-manage medications? Now on the next slide, I'm going to present a visual, and I give you a spoiler alert. This may be a disturbing image. This is in reality in many homes. We don't need We don't need to let this run our lives. And I ask you, what's your first impression when you see this picture? It might be, oh my goodness gracious, I'm glad I'm not that individual that has to take those medicines. Or maybe you're a healthcare professional and says, oh my goodness, where do I start? However, I want to flip the script here and say, wait a minute, what if right now, after that we use this process we're about to talk about, you say, oh, actually, all of these medicines do have a medical reason. They're working for me, they're safe, I know how to take them, I'm doing them right. That's the paradigm that we're going to change to, we wish to change to here through this effective medication self-management concept. So it all boils down to a systematic four-step approach to better understand why and how to take medications when and if we need them. In other words, it's a way to determine the appropriateness of your medications. It's going back to the beginning. Much of the time we have confusion because we're in the middle of taking medicines and we never take that continuous process to go back and reassess. Well, now we can do that. So confusion occurs as medications come into our lives at different times from different sources, sometimes with not clear direction and planning. And we can reduce this confusion by addressing four aspects of each medication you're taking and doing it in this order. Do I know the intended medical reason for taking each medication? Do I know how each medication is supposed to work for me? Am I aware of side effects specific to my mix of medications and conditions? And then am I able to take and afford medications? We don't start at the bottom. Because if we start, make sure that you take a medication that doesn't have an intended medical use, is not effective or safe, that's going backwards. It's crazy. So that's why we start in this order. So here it is, the Minnesota North Star Effective Medication Self-Management Toolkit. I provide the link to the toolkit above. It's freely available, and please disseminate it as widely as you wish. It's a self-paced digital training module with animated case scenarios, resource links, and a self-efficacy checklist, which I'll talk about here in just a minute. These animated case scenarios, there's actually a couple in there which actually are a little bit humorous, if you will, and I really invite you to review those. It's intended for healthcare teams and for persons, families, and caregivers. It's chock full of all kinds of information and resources that are intended to help you make sense out of taking medications. So if a person needs help with why they're taking a medication, or if it's working or safe, or how to take and afford it, the toolkit is a roadmap for our healthcare teams to focus their help that they can provide to you. So we developed this self-efficacy checklist, and it was really put together using a self-efficacy scale construction that's very common in nursing. And so you use a scale of 0 to not confident to 10 to be very confident. 7 questions. I understand why I'm taking each of my medications. 0, not confident, 10, very confident. I know how each medication is supposed to work for me. 3, I'm confident my medications are safe for me. I've adjusted my daily routines to take medications. 5, I know how to keep medication costs reasonable. 6, I know how to work with my care team when I have questions. And 7, I am confident that I can manage my medications. So if you're a person that responds with a score of less than 5 on one of these checklist items, then that really is a signal to our healthcare teams where we can focus our help. I'll use an example, a very common one. So let's say you're taking a low-dose cholesterol medicine, such as they call them statins, and you just love to have a half a grapefruit every now and then. But every time you get your prescription bottle, it says don't take with grapefruit. Well, you know what? You might be able to take that because the interaction is with a large glass of double-strength concentrated grapefruit juice. And really what it does is to slow the metabolism of the medication. So you may be able to take that half a grapefruit and you're more confident then. So now what? Can this four-step approach actually work in your home? It's the so what question. So we developed this toolkit using this four-step approach, and we then went to the next step of feasibility testing of the toolkit. And we did that through 2 focus group sessions at 2 independent senior apartment buildings, one in Burnsville and one in Bloomington. We started out, I was served as the facilitator for this. And we provided an overview of why and how the toolkit was developed, just like we just did. Described the systematic 4-step process. Previewed the animated prescribing cascade scenario that's in here. Asked participants to share stories of medication challenges. Restated each story within the 4-step process, and asked participants to share insights on how this can help them confidently manage medications. And I just might add on the side, this prescribing cascade scenario is like a composite of patients that I've dealt with over much of my life and some of the incidences. And at the first focus group, one woman raised her hand at the end and she said, Dr. Isaacs, that's exactly what happened to me. And I said, what do you mean? She says, and each one of the medications that you had in there in this prescribing cascade is what happened to me. And I got chills up the back of my spine saying, oh my goodness gracious, this is a real individual that had experienced this like so many of us have. So here are the findings from this feasibility testing. There were a total of 39 participants aged 62 to 97, 19 at the Burnsville site and 20 at the Bloomington site. And all 39 responded yes to the research question that they perceive the toolkit can help older persons successfully self-manage their medications. We also did internal consistency testing on the self-efficacy checklist. There's a measure called Cronbach's Alpha that goes from 0, which means it's not very consistent, to a score of 1. And anything approaching 1 is a high-level internal consistency. And there are also many key insights from that the participants have provided. I've just listed 3 of them here. One that struck me was at the very first session, as we got done to the end, they raised their hand and said, Dr. Isaacs, how long has this 4-step care process been in place? And actually, we developed this in pharmacy a little over 30 years ago to help patients make sense out of medications. And she said, wait a minute, you're telling me that this has been around for 30 years and this is the first time we're hearing about this 4-step process? Kind of struck me to the core, quite frankly. And so the second one was that when medications are deprescribed, when they're no longer appropriate, I won't be upset because I was previously told I'd be taking medications for the rest of my life. And I want you to think about this for a minute. Many times we have chronic conditions and we're told, oh, you're just going to have to take medications for the rest of your life. And then as we move on through life, we may not need it or may not be working, and we're told, oh, no, never mind, you don't have to take it again. Well, that can be confusing to patients. And because now the context is we understand the appropriateness in your particular case. And the third insight was, oh, thank you for helping me. Now I have a better idea of when and how to get help from my health team related to my medications. So how do you make this toolkit work for you? I strongly recommend you review the 20-minute toolkit with family and friends. Hey, make it a Netflix night, quite frankly, if you could. Or around the Thanksgiving dinner table while you're waiting for the turkey to bake. And then go through that toolkit. Complete the self-efficacy checklist to pinpoint where you or a loved one could use more help within the 4-step process. Then reach out to your health team to get help when you're not confident about any of the 4 steps. And of course, please contact us at the Minnesota North Star Geriatrics Workforce Enhancement Program. Maybe you want to have a small group educational presentation or test this out. I provide my email here for just that purpose. I'd love to help you. And the other thing is I can help connect you with individuals in your healthcare system who may be able to help you. Here in Minnesota, we're very fortunate. 12 of the 12 or 13 leading healthcare systems, they've designed teams that may include, in many cases, include pharmacists to help you guide you through this systematic 4-step process. And I just want to acknowledge some colleagues who have helped. Obviously, colleagues at the Minnesota North Star Geriatrics Workforce Enhancement Program are my colleagues in the Interprofessional Geriatrics Coordinating Council, my co-author of the toolkit, Christine Talley, in the School of Nursing, Janet Shanlin and Susan Wolf were the toolkit production colleagues. Believe me, I have very little artistic talent, and what they did to produce this toolkit over the 9 months we worked together was amazing. And our funding sources were the Agency for Healthcare Research and Quality, my Department of Pharmaceutical Care and Health Systems, and also the Clinical and Translational Science Institute. I would be happy to answer questions at the end and look forward to the discussion. And with that, Joe, I'll turn it back over to you.
Thank you so much, Dr. Isaacs. Wonderful presentation. Again, I encourage everybody who's attending, please use the Q&A box in the lower center of your Zoom screen to ask questions, which we'll get to at the end of our presentations. And then if time permits, our panelists certainly are free to directly answer your questions in the Q&A box as well. So it's my pleasure now to bring in Lynn Steffen. Dr. Steffen is a professor in the School of Public Health. Dr. Steffen's research areas and expertise include aging, nutrition epidemiology, cardiovascular disease epidemiology, diet assessment, diet patterns, and nutrition in older adults. Dr. Steffen, can you talk about nutrition and health for older adults, please?
Yes, after I unmute. I'm happy to be here and thank you. So Joe just told you that my expertise is in cardiovascular epidemiology as well as nutrition. I also teach a graduate level course in nutrition and aging. So I have 10 minutes to teach you all I know about nutrition and aging, and that's just not enough time, but I'll try. Oh, let's see. I don't have any conflicts to disclose. So as we age, there's many factors that influence our health and nutritional status, especially in adults 60 years of age and older. So there's a chapter in the 2020-2025 dietary guidelines that focuses on diet and health in the older adult. And I suggest that if you are interested in aging, go to this website, dietaryguidelines.gov, and review the chapter. It's a wealth of information. Here is a table which shows a limited number of physiologic changes that occur in older adults, showing the changes on the left-hand side of the column, and the right-hand side shows the associated changes in nutrient requirements. I'll just mention a few of these. One of them is decreased muscle mass and strength, which goes along with decreased need for energy intake, but an increased need for high quality protein. Actually, we start losing muscle at around age 30. And so we really should start consuming a higher quality protein at that time. But by the time we reach age 60 and 70, we lose muscle mass at a faster rate, as well as muscle strength and function. Another item I'd like to point out are as we age, we have increased cognitive impairment, as well as oxidative stress. And with this, we should consume more antioxidants, vitamin C, vitamins E, EPA, DHA from fish, beta carotene. So basically, I'm telling you to eat, older adults should eat more fruit and vegetables and fish. Another thing that happens when we age has to do with bone health. We have decreased calcium availability and along with that, decreased bone density. And so we have an increased need for calcium and vitamin D. This slide shows the average food intake data collected from older adults who participated in a national survey called NHANES. So the aqua blue, well, they're not circles, but I guess rectangles show the recommended amount of food intake that we should be consuming. For example, total vegetables, total fruit intake, total grains, dairy, and total protein foods. Now the black dots, or maybe they're purple on your screen, reflect the actual intake of these food groups. And as you can tell, older adults are not consuming the recommended amounts of these food groups. However, older adults are consuming too much added sugar, saturated fat, and sodium. And this is what happens when we're eating too much added sugar. My graduate student, Soyuni, she conducted a study looking at added sugar intake associated with adipose tissue. She looked at pericardial fat, visceral fat, and subcutaneous adipose tissue measured by CT scans. And here on the right-hand side, you see the bar charts. The light blue indicates less than or equal to consuming 50 grams of added sugar a day. The darker blue represents eating greater than 50 grams of added sugar per day. And as you can see, if you consume more than 50 grams of added sugar a day, you're going to have more pericardial fat, visceral fat, and subcutaneous. Now, pericardial fat is the fat that surrounds your heart, and that actually is related to coronary artery calcium. So it really is a good idea as we're aging to cut down on added sugar intake. Here is the table that shows a variety of studies about diet patterns relative to several health outcomes. One, cardiovascular death, atrial fibrillation, elevated blood pressure, mild cognitive decline, and diabetes. And I'm not going to go through each study, but what this slide is generally representing that consuming a Western diet is associated with greater risk. Now, our Western diet is represented by greater red and processed meat intake, greater refined grain, greater added sugar consumption, and fewer fruit, vegetable, and whole grain consumption. Whereas on the flip side, a plant-based diet or the Mediterranean diet is associated with better health outcomes. I want to point out, because older people, i.e. I'm older, and so therefore I worry that, cognitive function is so important to me, that a Mediterranean diet is associated with less cognitive decline. Okay, so what should an older American eat every day? And, the last two slides really reflect that one should be consuming more fruit and vegetables. So based on a 2,000 calorie diet, the dietary guidelines recommend that an older person consume 2.5 cups of vegetables a day, 2 cups of fruit, whether it's cut up or whole pieces, 6 ounces of grain products. Now, what is 6 ounces of grain? So it could be 1 slice of bread represents 1 slice. So you could consume 1 refined piece of white bread or multigrain bread, whole grain bread, pasta, which would be like a half a cup of pasta or a half a cup of rice. Now, half of the grains should be whole grains, whole grain bread, brown rice, whole grain pasta, those types of products. And then next one should consume about 5.5 ounces of protein. And protein foods include, eggs and lean meat if you're a meat eater, fish, legumes, nuts, seeds. Those are protein sources. And also limit your sources of added sugar, sodium, and saturated fat. Now, here is a really great source. If you're confused about, well, how do I plan my meals? So there's another website associated with the dietary guidelines. It's called myplate.gov. And here you see how your plate should look. So half of your plate should be fruit and vegetables, and the other half should be grain products and protein. And notice that the protein is a little bit smaller, portion size than the grain or the vegetable portions. And then the blue represents dairy, whether you consume an animal dairy product or soy or lactose, type of dairy product or yogurt. One should add dairy to your meals also. And over on your left-hand side, you see this little pink kind of warning signal that says limit. So limit your added sugar, sodium, and saturated fat. I guess I want to give a plug for sodium as far as consuming less sodium, because sodium is actually related to blood pressure. The more salt or sodium you consume, your blood pressure increases with age. And packaged foods typically have a lot of sodium in them. Not all packaged foods, but reading the food label on a package is actually quite helpful. And so finally, and maybe most importantly, healthy eating includes sharing meals with family and friends. And for those who have difficulty chewing or swallowing, finding foods that are acceptable to eat is really important. And finally, handling food safely during food preparation to avoid foodborne illness is also important because as we age, immune function declines. I'd like to acknowledge So Yun, my graduate student who helped me put together this presentation. Thank you.
Thank you so much, Dr. Stefan, for that wonderful presentation. It's certainly spurred a lot of interest, as I can see in the question and answer box. And now I'd like to turn to Dr. Tatiana Shippey. Dr. Shippey is an associate professor in the School of Public Health, where she also serves as associate director of research for the Center for Healthy Aging and Innovation. As a social gerontologist, Dr. Shippey's work focuses on what really matters to people as they age, including quality of life measures such as social interactions with others and meal enjoyment in long-term care settings, and the role of racial, ethnic, and socioeconomic disparities for older adults' quality of life. Dr. Shippey, can you share more about quality of life as we age?
Absolutely. And thank you so much for having me here. Such a pleasure to connect with all of you. Really very happy to use my 10 minutes to talk about a topic that is of great importance to me, and that is, how do we promote quality of life for older adults who live in long-term care settings? I don't have any conflicts of interest to disclose, and I would like to acknowledge funding for my research, and especially what I'll be sharing with you today. And this work has been funded by the Fessler-Lampert Chair on Aging, National Institute on Aging, and the National Institute of Minority Health Disparities. I would start by giving a little bit of an introduction that, as I shared, my work is focusing on promoting quality of life for people who live in long-term care settings. And this research, and really a passion of mine, has come from my experience of living in a long-term care facility now more than 2 decades ago when I was a graduate student. And it was during this time of living in the facility as part of working on my doctorate in gerontology that residents told me that quality of life mattered to them, that this was something that deserved more study. And so I just want to share a few of kind of resident perspectives on this issue, where these are quotes from residents that I interviewed for my work. And they said, aging is not easy, but what choice do we have? You just have to do your best and take it a day at a time. Or said, there are some people who are so private and shy that they don't participate much. Mind you, this is in the context of living in a long-term care facility. But those of us who do, we do have a family feeling. We have a Bible, we have a Wednesday morning Bible study that we enjoy. Or I'm here because I didn't want to be a burden for my children. They have enough going on in their lives already. And that was the reason that many had to move to a long-term care facility. So what I'd like to share with you briefly are just some of the key highlights of my research on the factors that influence quality of life for people living in nursing homes in particular. My work also focuses on assisted living and home and community-based settings, and I'm happy to talk about it during Q&A. I also want to talk about disparities by race and ethnicity in quality of life for people in nursing homes, and just quickly highlighting some implications for policy and practice. Now, nursing homes have received quite a lot of criticism recently, right? If you've read any kinds of stories about long-term care during COVID, we saw that nursing home care in the US is really struggling and truly needs to be improved. And many also critiqued whether we even need to have this kind of a setup of having nursing home care as part of our long-term care system. And I would argue that nursing homes are a key element of long-term care delivery in the US, in part because they care for some of the most vulnerable older adults that we have. In fact, every year, more than 1.5 million older adults receive care in nursing homes. And this number is projected to increase up to 3 million by 2030, which is not so far away. We also know that close to half of Americans over the age of 65 will spend some time in a nursing home in their life, usually for rehab, but about a quarter will stay a year or more, and that's usually at the end of their lives. And we know that public dollars or Medicaid fund the majority of nursing home care, so that is coming out of your taxpayer dollars. So I would say we must all unite and join forces on improving the quality of nursing home care. But what is quality, right? And when it comes to measuring quality of nursing home care, most research has focused on clinical aspects of quality, which are important, but as many of my resident friends told me, don't capture many, many other aspects of their well-being, which is what motivates them to wake up in the morning. And that is autonomy and dignity. Are people respecting your personal space? What about relationships with staff and other residents, food enjoyment? And so things that motivate us, that give us a sense of who we are. And that's where current measures fall short. And yet residents and family members say that these measures are important. And also it's been encouraging to see that in the last few years, we see other national bodies, including National Academies of Science, Medicine, and Engineering, joining these calls and stating that when it comes to measuring nursing home quality, we need to focus on person-centered measures, such as residents' quality of life and family satisfaction, in addition to clinical measures. And so my research, which has focused on quality of life, has a number of findings as to what are the factors that actually impact quality of life. And when I measure quality of life, it's a multi-domain construct, which, as I said, includes measures of mood, food satisfaction, privacy, autonomy, dignity, relationships with others, social engagement in activities in a facility. And what we find is that resident factors impact quality of life, probably not a big surprise. And that is residents who have more limitations in activities of daily living, residents who have diagnoses of Alzheimer's disease and related dementias, as well as mental health conditions such as serious mental illness, on average report lower quality of life than residents without these conditions. But we also find that facility factors play quite an important role in impacting quality of life. And some of the key factors here that have been consistent across my work have been Medicaid as the payment source. And so that is facilities that rely primarily on Medicaid. On average, residents in these facilities report lower quality of life due to lack of resources. Also, my work found a very important role for staff hours, probably not a huge surprise for anyone here, but what's unique is the importance of activity staff hours for residents' quality of life, as well as registered nurse hours. Facility size and location, residents in larger facilities on average report lower quality of life than those who live in smaller facilities. Facilities that have a high rate of administrator turnover, probably not a surprise, usually have lower quality of life for their residents, as well as ownership status is also associated with quality of life, and that is residents in for-profit facilities usually report lower quality of life than those in non-for-profit facilities, and we can talk about a variety of mechanisms that drive these relationships. In addition to looking at individual and facility factors that influence quality of life, I wanted to share with you that it is really important to look at equity, and does everybody have an equal chance at high quality of life in long-term care facilities? And it used to be that most of the nursing home residents were white, but that dynamic is rapidly changing. And in fact, the proportion of older adults of color in nursing homes has increased drastically in the last decade and is projected to surpass that of white adults by 2030. But many of our long-term care providers and facilities are not prepared for this change. And in fact, as my research shows, that residents of color report significantly lower quality of life than their white counterparts. And the gap is especially large for food satisfaction, programming and activity participation, and relationships with staff. And we also find that white residents who live in primarily white facilities, which could be used as a proxy for having more resources, I talked about Medicaid as an important source of funding, usually have the highest quality of life scores. But it's Black residents who live in primarily high proportion Black facilities who report the lowest scores. And so what are the implications of these findings? And I wish we could have hours to talk about this because I really care about this topic. But just as a summary, a couple of key takeaways from me. First, our measures need to stay relevant for the changing nature of long-term care. If we want to invest in what matters for us, I would argue that we must capture person-reported measures of quality, such as residents' quality of life and family satisfaction. And when I share this work nationally, and I serve on several national committees, always tell people that this can be done because Minnesota is doing it, and it shows that it's feasible. In Minnesota, we have implemented resident quality of life measures since 2005. We also have measures of family member satisfaction and experience of care for short stay, rehab, nursing home residents. And, when we look at our website clicks, we see that these are the measures that get most attention because they do matter for consumers and they should matter for providers in trying to improve them. Also, as my research shows, we really do need more investment, financial and other investments in having more staff hours per resident day. And this extends beyond clinical staff, which are so important, to activity staff, which we see have such a direct impact on residents' quality of life. We also really need new models of care delivery for how nursing home care is done in this country. And that means we need the types of nursing homes that can foster not just sort of physical care needs, but also create more positive social environments for residents. And then finally, we need to focus on equity, and we must invest in interventions that address quality of life for residents of color. And this really means more partnerships with community organizations, and partnerships with facility, especially for those facilities that have few resources and don't have the capacity on their own to promote a residents' quality of life. So thank you so much for your attention. I hope you'll have questions and we'll engage in a discussion together. And these are just some of the questions. Here's me was one of my research assistants visiting with residents in one of the nursing homes here in the Twin Cities. And then the one on the upper right is a photo of some of my team members doing a community presentation about our work. Thanks so much again.
Great. And thank all of you for, again, very intriguing set of presentations that have spurred many questions. Our panelists have done a great job of answering many of these questions in the text box, but I'd like us to move on to the questions submitted by you. Again, as a reminder, you can submit your questions to our three panelists using the Q&A box, which can be found by clicking on the Q&A button at the bottom of your Zoom screen. And now I realize some of these questions have been answered already, but I think some of them are important and broad enough that perhaps we can revisit them in our discussion. And I'm going to start with you, Dr. Isitz. I think this is a great question, a very important one. Why do hospitals and nursing homes continue to push antipsychotics for older people in their care? They said my dad had dementia, which, again, the person submitting this question felt was ridiculous. But let's treat pain and presenting conditions without pushing antipsychotics as a first line of treatment of dementia or otherwise. So, Dr. Isitz, would you like to comment on that?
Yes, Joe, thank you very much. Just as I serve as a nursing home consultant pharmacist for a number of facilities, and this is one of our foremost situations that we deal with. It's, part of it is that they had this long history of the use of antipsychotics as chemical restraints that go back many, many years. It's almost like this culture of, well, we don't have enough people to use non-pharmacologic approaches for one-on-one redirects and what have you, so we'll just throw antipsychotics and subdue them. And this is all wrong. And so this is really where all of us work together. So for instance, in the facilities I serve, we get together on a regular basis as what I call a behavior monitoring team. And what we actually do then is that we work with the nursing staff to actually measure some of the target behaviors. Let's say it might be biting or it may be striking out, is that we actually then document that in terms of number of occurrences so that we have a measurable way to determine what these behaviors are and how the use of non-pharmacologic as well as some pharmacologic properties are actually working. Much like measuring blood pressure. If you don't measure it, you don't know how you're doing. And so that's one of the first steps. And then the other one is to really do that deep dive, is that what are the underlying conditions that could be causing a number of the behaviors. In some cases, individuals have a schizophrenia, a documented medical condition that for which those antipsychotics are indicated. However, using these medicines for individuals with behaviors does not have an approved FDA intended use or indication. And so that's why we have to take great pains to work together to understand the underlying causes for the behaviors. And it may not be a dementia. It may be something else, as our listener has said, well, let's treat the pain And you know what? Maybe we do have to use some narcotics or opioids to treat the pain. You know, it's what's the alternative? Throwing antipsychotic medications at you? So this is really a great question. Thank you for asking.
It really is, Brian. Thank you. And thanks for that wonderful answer. I wanted to share a quick slide for you. This is a dementia education slide I provide to communities regularly. And this is actually from the Alzheimer's Association as to when should antipsychotics, if ever, be used when working with someone with dementia. And really, as Dr. Isitz mentioned, they should never be used as frontline treatment. And also, as the questioner had implied, it's really for these three reasons and situations when antipsychotics can feasibly be used for people living with dementia. And otherwise, if it's used as kind of a frontline treatment to simply manage the behaviors we know that are fairly regular symptoms as part of dementia, that's highly inappropriate and has a number of really potentially adverse effects, particularly for people living with dementia. So it's unfortunate that that still continues as practice. But again, it really emphasizes the need for person-centered care that you heard Dr. Shippey talk about to some extent, which we'll get to here soon in our discussion. But I wanted to turn to Dr. Stefan next. Again, Dr. Stefan has been answering many of the questions you posed related to diet and healthy aging. And Lynn, I'd like to ask you, what is acceptable as a high-quality protein?
That's a question I've been answering. So, okay, so the research basically says, protein is really important for maintaining muscle mass as we get older. And so the high quality would be meat, chicken, fish, your animal proteins. However, if you're vegetarian or want to eat a more plant-based diet, eating complementary plant-based proteins is important. Now, what do I mean by complementary? So that would be something like eating beans and rice, or beans and rice and tortillas together. Okay, peanut butter sandwich, macaroni and cheese, tofu with rice, hummus with pita bread, a grilled cheese sandwich. So the cheese and the bread have different essential amino acids, but one food by itself does not have the all of the essential amino acids necessary to promote or maintain muscle mass. And one could go on to the web, just Google complementary protein food sources, and you're going to get a whole long list of foods that kind of go together. So high quality would be your animal sources, but then, if you're vegetarian or want to go more plant-based, then it's important to eat these complementary proteins.
Wonderful. Thank you, Dr. Stefan. So Dr. Shippey, tell us more about trends in long-term care facilities and exploring options other than nursing homes. It's kind of a large question, but maybe take a piece of that to answer.
No, that's a really great question and really important question, because again, nobody wants to go to a nursing home, even though many people do have to use nursing homes for rehab. And so what we have seen as one of the two big growing trends, one, there has been more, and the term I'm going to use here is rebalancing, and that is that there has been more state effort to use Medicaid dollars toward home and community-based services where individuals can receive nursing home level of care at home. And I know that that's what most older people desire. And in fact, I am funded, I currently have a 5-year grant from National Institute on Aging, where we're looking at satisfaction with services for older people who receive Medicaid-funded home and community-based services. And I can just give you a very quick sneak peek that while it is, again, a type of long-term care that's much more desired by older people and their family members, some of the barriers that folks bring up are transportation. That's something that we see a higher need for, and also higher support needed for caregivers of those with dementia who are caring for their loved one at home. So lots of benefit, lots of pros, but there are some challenges there as well. And then the other trend has been a large growth in assisted living. And in fact, assisted living has just been growing across all states and really has been perceived as a very desirable option relative to nursing homes. And it is in many ways, except, as everything, there is a caveat, is that assisted living is primarily private pay funded. And you may have seen a very sad story out of Wisconsin last week where some Medicaid residents were being evicted from their assisted living residences because they ran out of private pay. And so while assisted living is a very promising model of long-term care that is growing nationally, one of the challenges is how will people pay for it if they don't have enough to pay out of pocket? And how can we increase public payments such as Medicaid to cover more of overall living spending so it's more accessible to more folks? That's the very, very quick broad
Right,
overview.
right. So Tatiana, maybe do you want to talk a little bit about rebalancing and what's happened in states and how many states actually in some cases even have or have had moratoria on building and on including any more nursing home beds in their state? Do you want to talk a little bit about that?
Yes, sure thing. And you kind of touched on this, Joe. So again, the big picture is that we know that most people don't want to go to nursing homes. We know that we need to invest in changing how nursing home care is delivered. There are new models of care out there, which I think are really promising, such as small home design, more home-like type nursing homes, but it all comes to funding. Can we get funding for those types of models of care? And so there has been greater recognition, as I said, on the policy space to invest more Medicaid dollars in these home and community-based designs. And in fact, not all states, of course, are equal in how much they spent on that. And if you're interested in seeing how your state compares, you can go to the AARP scorecard. AARP posts an annual scorecard, which allows you to compare your state on different metrics, including how much of the Medicaid dollars is going toward institutional care, such as nursing homes, relative to home and community-based settings. So that's a great tool that I would really recommend. Minnesota, since we are based in Minnesota, is leading the nation in terms of their rebalancing efforts, as well as states such as Oregon and Washington that have spent a lot more of their Medicaid dollars toward home and community-based settings versus nursing homes. Minnesota, for example, has a moratorium on any new nursing home beds in the state. And so that means that those Medicaid dollars are going to go toward home and community-based settings, which I think is really, really important. But we also need to pay attention to transportation and these other existing barriers to adequately meet the needs of caregivers and older adults who live in the community with disabilities. Joe, if you want to add anything else, please do.
No, I think that's wonderful, Dr. Shippey. And one thing, and one thing I'll do is I'm going to provide an article for everyone that came out of the AARP. A policy analyst there who's been working in the area for a long time, Susan Reinhard, came out with this really great article on back in the fall about, we already have identified innovations in long-term care. And what we need to do is to really scale them up and make them available. And you've heard Dr. Shippey talk about a few of them. Things like they're called the greenhouse model is one example. So these small nursing homes that actually are much more apt to provide the person-centered care that you heard Dr. Shippey refer to. There are other innovations as well that should be scaled up. Novel ways to integrate acute and chronic disease services within the community. And there are many other examples. There are several other examples as well. There are around 5 or 6 of them. I'm going to share that as a resource for everyone after the presentation today. But let's turn to some of these other great questions you've been submitting. And we're going to turn to you now, Dr. Isitz. Again, this is a really good question. Do you have any recommendations for family members managing medications for loved ones whose first language is not English?
Yeah, that's a great question. I've thought about this. And so what we are looking at is this toolkit we've developed is actually been developed also for individuals who are maybe frail or have some cognitive impairment. All right. And so what that means is that if you're a family member and let's say you're the individual that's helping someone else manage their medications, then that you can actually be that surrogate for that individual to answer the 7 questions in the self-efficacy scale, for instance. Now, what is interesting is that the question is what happens if that caregiver doesn't speak English as well? And so I think that's an important point. There was another similar question. This is brand new, hot off the press, this toolkit. One question was, does this work with assistive technology? I think we need to talk about that in our meeting tomorrow, Joe, as well as what about translating this into other languages? So we're going to take that back to the drawing board, and I thank you for that question.
Yeah, again, really important question. So Dr. Stefan, for the changes in diet and nutrient requirements, could those requirements be obtained through food rather than supplements?
Yes, I actually recommend getting your vitamins, minerals, fiber, calories, everything from food as opposed to dietary supplements. And actually, maybe Dr. Eilitz can talk about dietary supplements and drug, supplement interactions, maybe even drug food interactions. But I definitely recommend getting, eating your vitamins, minerals from food, So again, I direct you to the Dietary Guidelines website, and, they have meal planning, resources. They can help with identifying, complete proteins or protein sources, all of that.
And Lynn, yeah, thank you. Dr. Isaac, Brian Isaac, I'll jump in here on that's one of the most common questions I get as well in terms of food-drug interactions. And quite frankly, what the best guidance I can give right now is, let's say your medicines are working, you're stabilized, and then you go and read something that says, oh, when I take my calcium, it interferes with my thyroid medication. I'm going to change everything. Well, don't change anything, because your body has already adapted to that interaction and it's stabilized. And so this, I think, is critical to bring up, is that yes, there may be an interaction, but it may not be harmful to you. So it can be very confusing, the literature we read every day. And so yes, there are some food-drug interactions, but many of them we can manage. And I also then put in the response the link to the National Institutes of Health Office for Dietary Supplements. Just issued kind of a new fact sheet on guidelines for supplement dosages.
Thank you so much, both of you. So I have another question here for Dr. Shippey. I think she's going to like this one. So Dr. Shippey, do we have a rating system for nursing homes in Minnesota? And maybe you could talk about your emerging work for other settings too here.
I do like this one, and I responded to it in chat. So I'm hoping, and I'm happy to put a link in chat for others, because Minnesota actually is leading the nation in terms of its rating system. We have what's called a Minnesota Nursing Home Report Card. I put the link in chat to the person who asked the question, and I'm happy to post it broadly. And really, this report card is so exceptional. I don't think I'm biased. I came to Minnesota because of the report card when it existed. A lot of this work was done by my senior colleagues who unfortunately no longer with us, Bob and Rosalie Kane, who are really, I would say, heroes in the field of older adult care, but they developed validated measures of quality of life. Some of the examples I gave you on food satisfaction, relationships with others, activities, and these measures have been incorporated into our state-based report card. In fact, our legislature has appropriated funds, which allows to have in-person interviews with a random sample of residents in all of our Medicare, Medicaid-funded nursing homes, which are all of our nursing homes in the state, to answer questions about their quality of life. And because up to half of people in nursing homes, long-stay residents in nursing homes, have some diagnoses of cognitive impairment, dementia, it is very important that these are in-person interviews so everybody can participate, and people with dementia can and should be included. And then these scores are rolled up and consumers can use them to select facilities. We also have scores based on family member satisfaction, and we have very good response rates with those, as well as measures of, as I mentioned earlier, satisfaction with care for those who are short stay residents. And those are very different questions, because when somebody's in nursing home for rehab, they're really not worried about relationships with other residents and staff so much as they're worried about, how admitting process of discharge, are their needs being met adequately? And as I've said, we have heard from consumers that these measures matter for them. And I'm really hoping that more states can adopt these kinds of measures.
Wonderful.
Thanks for
Thank
that
you
question.
so much. Yeah, thanks, Tatiana. Again, great answer there. So, Lynn, tell us more about non-Western diets and their impact on healthy aging.
I was answering questions there. So a Western diet pattern, It's actually the typical diet pattern that people are eating in the US. And this pattern is typically high in red and processed meat, high in refined grains, low in whole grains, low in fruit and vegetable consumption, high in added sugar, and saturated fat. So the Western diet pattern in several studies that I've conducted, as well as others, have shown that the Western diet pattern is associated with higher risk for cardiovascular disease, higher risk for cancer, higher risk for weight gain, because the Western diet pattern is low in fiber. Fiber seems to be kind of like this magic nutrient where if you are consuming a diet high in fiber, you actually have a lower risk for diabetes, and either maintaining your weight or even weight loss. So that's basically a Western diet.
Thank you so much for that, Lynn. Appreciate it. Turning back to Dr. Shippey here, in terms of quality and well-being, how can loved ones be more supportive of older adult family members?
I'm sorry, could you say that again, Joe? How can loved ones?
How can loved ones or in this case, relatives or other close individuals be more supportive of older adult, I'm going to say older residents, let's say in the nursing home and residential settings?
Yeah, thank you for that question. I know we don't have a lot of time, but two things I would like to emphasize from my own research, and that is that often, you may be surprised by this, but more often than not, values and preferences for care between older person and their family members are not always aligned. My research, in fact, has looked at diet pairs, a pair of a family member and a resident, in terms of what matters more for them. And we find that often family members really prioritize safety, while residents tend to prioritize and value autonomy more. And so I think one potential way to answer this question on how can loved ones better support or support the loved one, especially if they're in long-term care, and that is listening to what really matters to that loved one. And that may mean for a person living with dementia that they want to take a little bit more risk. That means they want more outings. Maybe, I know, for example, I've seen what some nursing homes do to prevent falls. They're using these restrictive devices that the person will not fall, but that's limiting the person's ability to walk and get around, and it's interfering with their quality of life. And so I think ultimately, if family members clearly want the best for their loved one, but it also means, listening to what it is that that older person wants for their own quality of life. And that may be difficult sometimes.
Thank you so much, Dr. Shippey. So, Dr. Isitz, I'm going to give you maybe 30 seconds to answer the last question. I'm 75 years old. My voice is changing and I need to clear my throat more frequently. Would it help to gargle with salt water?
All right, that's not a question I get every day. That's here's actually that is a great start. It certainly is a good start. I think if you can take these home remedy starts, maybe some soothing. There's called a laryngitis spray. It eludes me for just a moment here. It has a little bit of a benzocaine in it, just to kind of give that larynx a break. And if it does persist, though, really, I strongly encourage you to see an otolaryngologist.
Wonderful. Thank you so much, Brian. Well, everybody, attendees, panelists, just so appreciate your time today. Wanted to thank all our panelists for their time and sharing their insights and how we adapt to life changes and maximize self-care and care from others as we age. And finally, I'd like to thank all of you for attending tonight. Your participation in the mini medical school means so much to us, the University of Minnesota, Office of Academic Clinical Affairs, and certainly our own Center for Healthy Aging and Innovation. Thanks again for joining us in these series. I think we have one final slide to show you, and it's really just encouraging you, if you want to continue exploring topics related to aging and health with us through CHAI. We have a very exciting free event. Again, it's a webinar virtual event this Friday, from 12 to 1:30 on addressing ageism, key issues and need for action. We are really thrilled to have Dr. Tracy Gendron from Virginia Commonwealth University and a national expert in ageism presenting for us. So please do join us. Very easy to remember information on registration right here, z.umn.edu/CHI Spring Speaker 23. So again, thank you, everyone. Have a wonderful evening. We so appreciate you being here with us tonight. Take care, everybody.